Good evening, everybody. I thank you so much for joining me tonight on YouTube Live. I'm Dr. Howard Elkin, the medical advocate. And May, being Women's Health Month, it's a perfect time to celebrate this important topic. Now, no doubt you've all heard that book, that famous book by John Gray, the renowned author, Men are from Mars and Women are from Venus. And nothing can be more true, especially as it comes to health. We're talking heart health, bone health, and brain health. So it really does make a difference. Now, first, I want to focus, of course, on heart health because, after all, I'm a cardiologist. So let me like to start off with a few facts and figures. And I'm really bad at numbers, so I have to read off my cheat list here. But I do it so that you see the prevalence of what's going on in the world right now, because we're not living in a healthy society. And also to give you a little shock value, women in heart disease, greater than 16 million women in this country, which is 44%, are living with some degree of heart disease. Heart disease kills more women than all cancers combined. You need to learn that. You didn't know it. And sadly, only about a half of women in this country actually appreciate that fact, meaning 56% recognize that heart disease is the number one killer. Most still don't really believe it. It has not hit home. So that's why we're doing this, because it's so important to mention that and emphasize that during Women's Health Month. In 2021, there were 661 deaths. That's one out of every five in women due to heart disease. In 2018, nearly 400,000. Now, to keep things in perspective, about 42,000 women die every year of breast cancer. So look, 42,000 versus way over 300,000. Yet half of people, even half of women, don't recognize that fact. So one of our jobs is to really disseminate that information, because it still needs to be broadcasted. About 800,000 women have a heart attack every year. Now, heart attacks are seen in both men and women, but women fare poorly when compared to men. Maybe it's because they're older, but generally more women die at the end of the first year of heart attack than men. And actually, if you look 5 years out, 47% of women are dying from a heart attack versus 36% of men. So women tend to do poorly with a heart attack. But it's an equal opportunity killer. And women are just as likely as men to have a myocardial infarction or a heart attack, but generally it occurs at much later ages. Like the average age for a male to have a heart attack is 65, but the average age for a woman is 72. So again, it's an age differential. One death per minute. That's in this country. A woman dies every minute of heart disease. Keep that in mind. Here's what I found to be not really surprising, but shocking, that women are less likely to receive CPR, bystander CPR, because people are afraid of being accused of sexual assault or inappropriate touching, which is ridiculous, right? I mean, someone's dying in front of you, and you're afraid to perform CPR. That's really, really sad. But it's not just in the elderly population. I want you to know that. And the heart disease is the number one killer in new moms, okay? And accounts for a third of maternal deaths, with Black women leading that, of course, which is a very important part. 10 to 20% of pregnant women have a health issue. That's huge, right? I mean, everybody thinks pregnancy is some kind of healthy phenomenon, but not in the population that we're currently seeing. An important point is that women that have hypertension, preeclampsia, gestational diabetes, endometriosis, not only is at a higher risk during pregnancy itself, but years later, which we didn't appreciate when I was a student, years later, women with these problems go on have a higher incidence of heart disease as they age. Again, gestational diabetes, hypertension, endometriosis, and preeclampsia. So menopause itself doesn't really cause heart disease, but accelerates the risk factors that we associate with heart disease. So let's talk about the aging female post-menopause. In general, I think most people know that women live longer than men on the average of 7 years. But women are also more frail, and they have worse health at the end of their life. So, I mean, are those 7 good years or 7 lousy years? I think it really depends on a lot of factors, but they tend to be more frail and don't do as well long-term wise. Now, let's look at the differences, because really women are from Venus and men from Mars. So one of the important things is The anatomy is different, anatomy and physiology. So look at the anatomy. Women tend to have smaller hearts and smaller arteries. Okay, and that does make a difference. And the cholesterol buildup is in different areas. In men, it's usually in the larger arteries. And although that certainly is the case with women, they tend to have built up in the smaller arteries. And we call that the microcirculation because we don't really see that on angiography. We don't see the small vessels, but believe me, they are involved with cholesterol buildup and they cause a lot of havoc in women. The symptoms tend to be different as well. Now, this whole thing about left-sided chest pain with, radiation down the left arm, we're seeing that less and less, but we rarely see that in women. With women, you don't even have chest pain. One of the most common presentations I've seen is nausea, weakness, faint-like feelings, just very vague symptoms, just a feeling of not being well or impending doom. It's really important because don't look for chest pain. Now, which is very characteristic in women, if they have neck pain or radiation to the jaw or the teeth, that is commonly associated with women, although most of the time you don't see it, but that is a red flag. Um, Women also have different diseases that mimic a heart attack, or they can have a heart attack without having coronary disease. One is spasm of the coronary arteries, and one is dissection. There's something called spontaneous coronary dissection, usually seen in middle-aged women that are basically healthy. And I've seen at least 3 or 4 cases in my career, in which it's a small artery that just kind of tears. It tears spontaneously for unclear reasons, and that can lead to a heart attack. Usually, fortunately, it's a small heart attack, but it is a heart attack. And the other one is Takotsubo's cardiomyopathy, the broken heart syndrome. And it's not clear how it happens, but the emotional stress can be, and the surge of stress hormones can be such a great that it causes a heart attack and a ballooning of the heart and actually heart failure. Fortunately, those with Takotsubo cardiomyopathy generally do heal spontaneously within a few weeks and are left with very little, if any, heart failure symptoms. Also, there's different risk factors to discuss that. With men, we don't have to worry about preeclampsia, gestational diabetes, and endometriosis, but these are disorders that can presage heart disease later in life. There's also a difference in diagnostic care. Lab testing, for once. There's this test called troponin. Actually, we're measuring enzymes that are released from the heart at time of a heart attack. Now, we recently had to change the values because we need sex specific thresholds. Like women tend to generate smaller amounts of troponin than men. So we have to keep that in mind. And we're just recently doing that now. We learned that it's very important that we keep the difference in mind when we're talking about enzyme elevations. Also, cardiac catheterization. I know I've done tons of angiograms on women, and of course men as well. But again, you could see normal coronaries at time of angiography in spite of the fact that they're having a heart attack, because we don't appreciate what the microcirculation. We can't look at it. These are not something that you can see visibly at the time of angiogram. What about heart failure? Heart failure is the most common cause of hospitalization in those over the age of 65. It's very common. And we see it in both genders, both male and females. Now, I have to explain to you the difference between systolic heart failure and diastolic heart failure. Now, systolic heart failure is what you think of as a weak heart, a heart that can't really pump blood from the ventricle to the aorta and to the rest of the body. That's systolic heart failure. Usually, that people have a poor or sick heart. Then we have something called diastolic heart failure, which is when the heart is supposed to relax. So basically, you have a heart that has to, if I can do this, squeeze and then relax, squeeze and relax. So squeeze, it contracts, blood is being sent all over the body. Relax, meaning blood enters the heart, and it's time to fill for the next cycle. Well, as we get older, the hearts become stiffer, just like our arteries have become stiffer. And most of the time, or at least oftentimes, we'll see women with heart failure have normal hearts. I mean, the pump seems normal, but they don't relax well. There's a relaxation problem or diastolic heart failure. And we see it in both men and women, but we see it more frequently in elderly women that present to the hospital in heart failure. The management is different, can be different, but the prognosis is still not good. So we do have to appreciate the difference in the heart failure between both systolic and diastolic. Now, is heart failure more prevalent in men and women? It's actually men have a slightly more incidence of heart failure. But women tend to be older when they're diagnosed with heart failure, and they often have diastolic dysfunction or problem with the relaxation, like I mentioned, and they don't do as well. Again, they're older, and they often have comorbidities like diabetes, hypertension, kidney problems, and other ailments. What about, let's switch gears now to the aging brain. Now, men's brains are about 10% larger than men. It doesn't mean that they're any smarter. They were any smarter, but the brain mass is larger in men. So does the risk of cognitive decline, is it more prevalent in men? Does it vary by sex? And I found a very interesting study. Like, it was a cohort study in 2021, and it pulled data from 26,000, almost 27,000 patients. And they found that women, as opposed to men, had higher baseline performance and global cognition and executive function. I don't know about you, but I was like, what in the hell is cognitive function? Is executive function? So I looked it up, and it basically means planning, self-monitoring, like monitoring your blood pressure, monitoring your labs, self-control, time management, organization. I think most of us can agree that women are better at that than men, and that's what this study showed. And even memory was better in women as they age. So they had this edge with executive function and memory. But women, as opposed to men, had faster declines in global cognition and executive function as they age. Not so much memory, but in those other functions. So what does it mean? That women may have a greater cognitive reserve than men, but they have a faster cognitive decline. And that's important to keep in mind. But what about Alzheimer's? So about 2/3 of Americans with Alzheimer's disease are women. So it's definitely more prevalent in women. And at age 65, 1 out of 6 women have Alzheimer's. With men, it's 1 out of 11. So it's clearly more noticed and more seen in men. Why? Well, women do live longer than men. That's the largest, the most significant risk factor for Alzheimer's is going to be age, no question about it. But now we're questioning how valid that really is. It's also linked to reproductive history, like the rate of a dementia. It can from you look at the time of when you first start menses or your first menstrual cycle to your last. Okay, the longer that period is, and the average age of menopause in this country is 51. The longer that period is, the less likely you are to have major decline in cognitive function because you've got the estrogen as a factor still there. However, with premature menopause, and that's usually defined by going into menopause less than age 45, but we're seeing it less than 40 now. So whether it's surgical menopause or natural menopause, this may increase the risk of cognitive decline. But the shorter period that you have estrogen functioning, it's important to keep in mind. Although one advantage is that there's probably less cancer, meaning breast cancer and ovarian cancer, because those are reproductive but these are hormone-driven cancers. But I think we're really more concerned about cognitive decline. So premature menopause is not a good thing. Also, you've heard me talk about genetics. I'm really into, excuse me, realizing someone's genetic or genome. So we look at this thing called ApoE allele. Okay. Now you get one allele from one parent and the second from another. So it's the ideal pattern is APO3/3. Okay, that's the most common, and that is the most beneficial pattern to have. But if you have 3/4 or worse, 4/4, that clearly increases your risk of developing Alzheimer's as you age. And for some reason, women with this allele are more at greater risk for cognitive decline than men. And they actually have more volume loss in the hippocampus. The hippocampus is a part of your brain which stores memory. So it's a bigger deal if you have the ApoE allele for women than a man. But really, what I like to focus on is the metabolic changes that take place with menopause, which is hormonally driven, right? So, and really, we're talking about insulin and cortisol, which are 2 hormones that come on with menopause. Everything else goes, right? Estrogen, testosterone, progesterone, but cortisol and insulin surge, which is not a good thing. Now, the average weight gain during menopause is 15 pounds. 15 pounds. But it's not a question of willpower. People think, oh, it's willpower or it's calories in equal calories out. That's BS. No one really believes that anymore. Those of us in functional medicine, it's hormonal changes. This is what happens in menopause, and this is what we have to change if you want to glide through menopause. So you've got reduced levels of, I said, progesterone, testosterone, and estrogen. And that in itself can increase your insulin resistance. And I've talked about insulin resistance a lot in the past. But what it really means is that your body doesn't recognize your own insulin, or it doesn't utilize it properly. So it can't enter the muscle cells where it should go. Instead, it hangs out in the circulation and isn't good. And then the pancreas makes more insulin in response to that. Not a good thing. And now, reduced estrogen levels in itself can lead to insulin resistance. And that's when your body just doesn't respond well to insulin, as I mentioned. Then the added stress of your hormone depletion and stress of just going through menopause and changes increases your levels of cortisol. We all know that cortisol is necessary for life, but it also is it's a stress hormone, and it floods your body in menopause. So what else aggravates? What else will bring on more cortisol, more stress? Well, poor eating habits, eating highly processed foods. And by the way, 67% of American adults are now eating ultra processed foods. That is like abysmal. Drinking alcohol, taking certain medications, poor thyroid function, sedentary behavior. These are all things that aggravate insulin resistance and cortisol excess. So in women, postmenopausal women, increased insulin resistance is associated with increased risk of diabetes, heart disease, and breast cancer. Okay, and so cortisol, that big stress hormone that surges with menopause, we want to balance it as well as we can. So we have to stabilize your circadian rhythm, which means we should go to bed around the same time and awaken the same time every day. Vicissitudes and your sleep-waking cycle isn't really healthy. So, and we also learn how to relax to relieve stress. I have to work very hard on this, and I think, but it's important. I have to do stress reduction every day in my life. We need to balance blood sugar levels, and we maybe try anti-inflammatory diet, and just reduce unhealthy habits. Okay, now what about osteoporosis, bone health? So menopausal women are susceptible to primary osteoporosis, and that's really due to estrogen deficiency. During menopause, the drop in estrogen is precipitous, leading to more bone resorption than actually formation, because bone is active tissue. It's not just calcium, and it's your body is constantly building new bone, but it certainly comes to not a screeching halt, but it decreases significantly with menopause. So why it's a big deal when women they have more bone loss than men? Because they have less bone mass to begin with. Okay, they typically have lower calcium intakes than men, and they also use weight reduction drugs, and they eat more weight loss diets, which tend to be low in calcium. That actually aggravates your bone loss. And women lose bone at an earlier age. When we do a DEXA scan, we're comparing your bone mass to a 35-year-old woman. That didn't make sense, does it? But that's our baseline. You have the strongest bones at age 35, then it starts going downhill. So women greater than 50 have 4 times higher rate of osteoporosis than men, and 2 times higher rate of osteopenia. Osteopenia is loss of calcium matrix. Osteoporosis is loss of living bone. And they didn't have fractures 5 or 10 years earlier when compared with men. Pretty important. Now, let's talk about hormones for a few minutes before we. And I love this topic because it seems to change all the time. So the estrogen was discovered back in 1929 by Edward Doisy from St. Louis, and it didn't take long. And it was actually discovered from extracts from placenta, but it didn't take long with the pharmaceutical industry to learn that we would reproduce this in the lab, and they did, and out came Premarin. It was approved in 1942. That's over 80 years ago. It was approved for hot flashes. Then there was this book that came out in 1966 called Feminine Forever. Can you be feminine without estrogen? And the author, who was a male, well, you think, no, that's not possible. His name was Robert Wilson. So he says, stop a woman's living decay. And the way to stop it is to give her estrogen. Now, it wasn't all that easy. And then research in the 70s, we learned that there's a risk of endometrial cancer associated with the use of estrogen. So then we used a synthetic progesterone, actually called a progestin, 5-hydroxyprogesterone acetate. Does that even sound anything near natural to you? It's anyway, but they came up with that, and that did help to prevent, that did spare the uterus of developing cancer. Then there were other books that came out, and that just stressed that there's a risk of cancer, breast cancer, strokes, blood clots. This went back around from the 60s, 70s, and 80s. And then the 80s and 90s were a really important time because it was looking really positive for hormone replacement therapy with regard to heart disease and in disease in general. And we needed more studies. And I'm just going to jump to the most important study that's been quoted over and over and over again. That's a Women's Health Initiative that came out in 2002. 160,000 women. The average age was 61. Okay, so that's like way past menopause, right? And it was stopped years before. It was supposed to be, I forgot how many years it was supposed to go on, but it was stopped prematurely because we saw there was increased risk of breast cancer, heart attacks, strokes, blood clots, all this bad stuff. In fact, but it was such a drastic revelation, I guess, so to speak, that doctors all over the country stopped prescribing hormones. In fact, the amount of hormone sales dropped 50% after the Women's Health Initiative. And that's kind of how I got involved. At that time, I was doing my anti-aging fellowship from the American Academy of Anti-Aging Medicine. And nurses and teachers in my area came to me and said, please, you got to help us out here because the gynecologists here in this area don't know from Shiola when it comes to treating hormones. They were all taken off their hormones and there was given no alternative. Entered the world of bioidentical hormones, which very few people knew about back then, except for functional medicine practitioners, people that trained in functional medicine and anti-aging medicine. But the Women's Health Initiative was not a perfect study by any such imagination. First of all, they used the wrong age. Why would you start therapy at a 61-year-old female when she probably already has heart disease? She's got it. So they had pre-existing conditions that were never diagnosed. The wrong estrogen. We were using horse-derived, Premarin, or a form of Premarin, or Prempro, which is horse-derived equine estrogens from the urine of pregnant mares. Nothing like human estrogen, okay? And the wrong formulation. They use oral versus topical, and we know that oral goes from the gut to the liver, where it can be changed to something more inflammatory. The last thing we want as we get older is more inflammation, right? And that's what happened. So it was a big movement developed, and bioidentical hormones became more popular. American Academy of Anti-Aging Medicine was a big spokesman there. It became more popular, and then Suzanne Summers' book came out, The Sexy Years, around I think it was 2003, and she really helped get this movement going because here there was a celebrity speaking out. I'm over 50. I'm getting fat. I don't sleep well. I'm itching. She was very open about what symptoms she was having, also libido, and it was a real quality of life issue because she had history of breast cancer. She was told under no circumstance you even consider HRT, but she went on a limb, did her research, and did it. Has written many books, as you know. She's a true spokesperson for anti-aging health, but especially when it comes to hormone replacement therapy. Because when I started off, I would give people these one. She's like, "Oh, do I read this?" And then when her book came out, I said, just read Suzanne's book because it's coming from the standpoint of a woman who can tell you exactly what it was like. So that really kind of helped pivot the use of hormones in my practice for sure. So there's 3 types of estrogens. There's estriol, which is highest when you generally are pregnant, estradiol, which is highest during childbearing years, and estrone, which is residual estrogen that's high in patients in menopause. Those are the 3 major ones. So what's my personal view on hormones? Okay, I'm an anti-aging medical specialist. So I am biased, and I tell people very glibly or bluntly that I think people, whether males or females, look better, feel better, and think more clearly on hormone replacement therapy. Does that mean I recommend it to everybody? Absolutely not. It's a personal choice. Some people breeze through menopause. Not many, but I think maybe 40% breeze through menopause and the rest suffer, have a difficult times. There is no reason why women should have a difficult menopause today with the use of bioidentical hormones. It's just No reason for it. So when I see doctors are still not giving it, or they giving the old, they either don't give it at all, or they'll give Premarin and Provera, which is synthetic progesterone I've talked about. I don't get it, but they just aren't educated because gynecologists have very little experience or teaching in hormonal therapy. You would think they do, but they don't. So now all this is mentioned in my book, little plug, from both sides of the table when doctor becomes patient. And I talk about all this, have quite a bit. The last chapter is how not to age ungracefully ever after. And we talk about hormones, but other aspects of aging. So um, one of the exciting aspects of estrogen therapy, besides its effect on brain health and bone health, is heart health. Because those of you that know me, I'm very keen on this thing called the endothelium. The endothelium is one cell layer that lines all 60,000 miles of our vessels. 60,000 miles. Can you imagine? That's all of us. And every one of those vessels are lined with endothelium. Now, as long as that endothelium is intact, I don't care if your cholesterol is 300. Ain't nothing going to happen. But because of age, smoking, high blood pressure, stress, pollution in the air, the soil, the water, more stress, poor sleep habits, more cortisol, diabetes, hypertension, diseases of aging, sedentary lifestyle, there's little microscopic breaks in that endothelium, which allows LDL cholesterol, which has been oxidized, to get in there and form plaque. Okay, that's really what happens. It's not the cholesterol is not the culprit, people. It's oxidized LDL that has managed to get into endothelium because we have a sick endothelium. Well, guess what? There are estrogen receptors in all these blood vessels. Okay, and that's been shown recently to have a positive effect because with estrogen receptors, you have an increase in this thing called endothelial derived relaxation factor, or basically nitric oxide. You all heard about nitric oxide. Nitric oxide helps you dilate arteries, increase circulation, it prevents vasoconstriction and thrombosis. So I think that way, that alone is a useful thing, of a use for estrogen. But again, it's not for everybody, but that's just one aspect I want you to know, that it can be very healthy for those with heart-related issues. Now I'm going to just mention something called endocrine disruptors, or estrogen disruptors, because there's xeno, or what we call fake estrogens, around there, and they're everywhere. Okay, they're everywhere. Synthetic chemicals and products like plastics and fragrances can mimic hormones like estrogen, and your body thinks it's the real thing, but it's not, and actually displaces estrogen on the estrogen receptors. It's just not a good thing, and it's most disruptive during periods of significant accelerated development, such as in utero and also in childhood. So these are the ones that are most affected by endocrine disruptors. It's a sad thing. So what do? We really have to wash our hands. It's not just for COVID. It's really to keep our hands clean from all the garbage and stuff that we have to touch on a day-to-day basis. Dust and vacuum frequently. Say no to fragrances. I mean, I know they smell good, but they aren't good for you. There's not a fragrance out there that's really healthy. They are endocrine disruptors. Avoid plastics. The worst is bisphenol A. I've read about that before. The BPA. You've heard of it, BPA, and phthalates. They're in all plastics. And guess what? Avoid cans. I didn't realize that cans are lined with BPA. They're just ridiculous. Eat organic whenever you can, because the pesticides are definite no. Filter your tap water, and also I didn't. This was just this was disarming to me to learn about essential oils can be are not universally healthy. Things like lavender oil and tea tree oil, like, it's ridiculous. Now, essential oils have been around for thousands of years, so I'm not ready to poo-poo them yet. I have to do more research on this, but that's a new thing to me. I didn't think about those being dangerous. I mean, I love having lavender, with my diffuser when I go to bed at night. It helps with my meditation, helps with relaxation and sleep. Now it's that's a healthy thing, so I have to look into that. There are natural remedies that I would end with. Phytoestrogens, or estrogens that we can get from plant sources, and the thing about soy is that it can be a good thing, but it can also be an endocrine disruptor. It can be an estrogen disruptor. So it's a double-edged sword, which is why you don't hear as many good things about soy today as you did, let's say, 20 years ago. Resveratrol, ligands are very good. Also, cruciferous vegetables, nuts are very good, and garlic. Okay. Those are the foods that help maintain estrogen balance. Supplements, B vitamins, vitamin D, boron, and DHEA. And there's herbal supplements like black cohosh, uh, um, evening primrose oil, red clover, and dong quai. Now, the other thing I want to end on is um, also another good thing about the whole weight control thing, since I tell you the average weight gain is 15 pounds during menopause, but estrogen can help with weight gain, well, can actually help with weight loss because it increases your metabolic rate. So as we know, as we get older, we become less active. Muscle does not turn to fat. What happens, the muscle kind of atrophies, the fat takes over, and you have a decrease in metabolic rate, which promotes more fat storage. Yet estrogen in itself can help that. Not synthetic estrogen, but bioidentical. And also pregnenolone and DHA can also help, which are two adrenal hormones I've not talked about. Pregnenolone is really important. It helps to limit the production of cortisol. I take it all the time, and also can help with memory. Now, how do we monitor people on HRT? The important thing is you need to go to a doctor who knows how to do this. Most gynecologists do not know how to monitor hormone replacement therapy. They just do a blood test. A blood test to me is useless once you've been on a topical form of anything, because it's not telling me what's happening at the tissue level. And that's really what I'm interested in. So I use a urine test. I used to use a 24-hour urine by a company called Genova. I stopped doing that. Who in the hell wants to do a 24-hour urine? Only women. I would never trust a man to do this. But now I'm using a test called the Dutch test. So much easier. It's just 4 collections, 2 at night, 2 in the morning, and you put like a litmus paper into a cup of urine, take it out, let it dry, and you submit 4 samples to the lab, and we get just as much information. And what we're interested in knowing is how you metabolize your hormones. There's a good pathway, there's a come see, come saw pathway, and there's a not good pathway. There's something called like 2-hydroxy. 2-hydroxyestrone is healthy. 6-hydroxy estrone is inflammatory, but we worry about 4-hydroxyestrone because that can lead to quinone production and DNA damage, and that's what we worry about when it comes to causing cancer. So you have to monitor that. I can't imagine giving hormonal therapy without doing that. And I also look to see how you methylate your hormones. That's phase 1 and phase 2. Phase 2 is are you a good methylator or a bad methylator? And we can alter that with supplements, okay, and certain holistic methods. So the important thing, if you're going to go on HRT, go to a doctor that knows how to monitor. I prefer the urine. You can do saliva as well, but there's big changes with saliva. I found the urine to be much more helpful. How often do I do it? At least once a year while a patient is on hormonal therapy, more often if I'm making changes. And that's it, guys. That's a lot of information, but you women deserve it. But don't worry, guys, because next month is Men's Health Month, and we will do something similar for the men. So let me look at these questions. Okay. Okay. I received a book. Oh, someone received my book today. Good. Okay, just make sure you do a review. By the way, I want all of you to get my book. Not just get it, but to read it. Because it's not just about my story. It's how I became my own medical advocate. And it was a little work. Even though I was a doctor, I had to learn how to take care of myself the right way. But the bulk of the book is not about me. It's about you, how you can become your own medical advocate without being a doctor or a nurse. And but most important, after you do the reading and enjoy it, go back to Amazon and please write me a review. On my Amazon page on the lower left-hand corner, I believe, it says write a review. It's very important because I want to make this book a game changer. But to make it a game changer, I need to be a bestseller. To be a bestseller, I need a lot of participation and a lot of reviews. So the more reviews, the merrier. And it's not just about me; it's about the book, how it moved you, how it, So please do that. Okay, we went over a lot of stuff. Is there a difference? Is there a different name for a calcium score test? Okay. No one knows about it here in South Texas. Well, they should know about it. It's not new, darn it. Calcium. Okay, so what it does, coronary artery calcium scan, which I do a lot of, detects calcium in the coronary arteries. Okay, so you get what's called a calcium count. Now, your ideal score is 0. Who wants calcium in the arteries, right? But as we get older, it's pretty likely that most of us are going to have a little degree of calcium. So the higher the score, the higher the risk. So if it's less than 100, you're considered low risk. If it's to 399, if it's less than 400, moderate risk. If it's over 400, it's high risk. But again, it only detects calcified plaque. It doesn't look at soft plaque, and soft plaque is the plaque that generally causes heart attacks and strokes. So, but there's a new scan. Okay, something new. There's a new scan coming out that I'll be involved with at Harvard UCLA called the Clearly scan, CLEERLY. And that combines CT angiogram with a peripheral IV with artificial intelligence, AI. So now we'll be able to tell the difference between soft and hard plaque and be able to give you to assess your risk by how your plaque actually looks. It's very exciting. So that's a new thing. It should be available. Clearly, it's really going to be big here. It's not even ready for prime time yet. But if you come to me, I can get it for you. And Medicare will probably cover it. But it should be the coronary artery calcium scan. That's the only name that I go by. It used to be called the God, they have different names, but I think if you just go by coronary artery calcium scan, you should find it. That tells you what it is. It detects calcium in the coronary arteries. It doesn't always detect your risk because your risk is more about the vulnerable plaque, but it is important. So please look for that. K2 with vitamin D, good, very good. If you have coronary disease or if you're concerned about coronary disease, you don't want to take vitamin D by itself. You want to take it with K2. So K2 as opposed to K1. K1 is more associated with blood clotting. K2 actually helps to transport calcium from your gut after you eat to where you want to go. You want to go two places, bones and teeth. You don't want to go into the heart valves or heart or the arteries. So that was one of the problems we found. If you go back 15, 20 years, women were given like 1,500 milligrams, if not more, of calcium every day by itself. And we saw that the incidence of heart disease was increasing. I don't do that. But I have my own bone formula called Bone Wise, and it has the right, much less calcium than me. I think it's 750 versus 1,500. Magnesium, K2, D3, boron, zinc, and probably something else that I can't remember. So nutritional therapy is very important to combat osteopenia and osteoporosis. I have never prescribed those drugs, whose names I won't mention, for osteoporosis because they will build bone, but they build inferior bone. And you have a better increased incidence of jaw necrosis and also fractures in the femur. Who the hell wants to see a fracture of the femur? That's your longest bone. So, but the best bones come from hormones. No question about it. Because estrogen helps to retard bone loss, progesterone helps to build bone, and testosterone, even in women, helps to give bone its tensile strength. So please keep that in mind. That, along with strength training, is going to help you. Okay, let's see. What is the recommended dose for CoQ10 for women at 7? I would say if you aren't taking a statin, the dose 100 milligrams is fine. It's fine. And you want to take CoQ10 with food because it's fat soluble. It's a large molecule, although it's ubiquitous in nature, therefore it's called ubiquinone. It's a very large molecule which is poorly absorbed, so you want to take it with food. 100 milligrams by itself, but if you're taking a statin or other medications that could deplete you of CoQ10, go up to 300. I take 300 a day. Okay, thank you for writing a review. Somebody mentioned that here. Okay, any other questions, guys, about monitoring hormones or anything at all? I mean, there's a lot of information I gave you, but I wanted to include this all because I thought it was important information, and women deserve to know this. And when it just shocks me to think that 50% of women out there still don't realize how prevalent heart disease is and why it's really their number one killer. When 47,000 die of over 300,000 of heart disease and 42,000 of breast cancer. So that's really one important take-home point. Okay, well, I know we've kind of gone over, so make sure I didn't leave any questions here. So let me look at my glass. Senior moment here. Thanks. Okay, when will you be back on YouTube? I probably will be. I'm kind of busy. I'm trying to put together a trailer to become a little more well known for what I do, especially with the new book and everything. But I will, excuse me, definitely do in probably 2 weeks, 2 to 3 weeks. And you please subscribe because when you subscribe, you should be getting an alert. But 3 weeks at the latest, it will be on men's health. That's true. And if you have other topics you'd like me to discuss, please let me know. Do it in the comment section, or if you're on Instagram or Facebook, you can private message me. But I'm always interested in topics that you want. I can talk about anything, but it's really for you guys. Uh, but I enjoy doing this. Okay, I guess that's about it. I meant to make sure I didn't leave anything out. So 2 to 3 weeks for sure. And okay, well, listen. Have a wonderful Memorial Day weekend, you guys. Enjoy yourselves. Be safe. Be careful. There's going to be a lot of people on the road, from what I understand. And I'll see you in a few weeks. So you will get the announcement. And please share this with other people, especially women. Um, Even though uh, I'm doing this live, after this is completed, within a few minutes, it will become a permanent part of my library on YouTube. And the latest one is always the first one you see as you open the channel. So please spread it around. Let's spread the word, and we'll go from there. All right, guys. Thank you. I'm very grateful for your presence, and we'll see you in a few weeks. Happy Memorial Day, everybody. We'll see you later. Thank you so much.